dear doctors, on behalf of Intas Oncology, I, Suresh Tiwari, welcome you all to this novel educational initiative of Mumbai Hematology Group. This is a webinar on a very interesting topic, what was new in the field of lymphoma in ASH 2023, which is relevant to clinical hematologists in India. And we are very grateful to Dr. M.B. Agarwal, sir, who has taken this novel initiative. So, sir is known to all. He needs no introduction. He is a stalwart and professor and head department of hematology, Bombay Hospital, consultant hematologist, Leelavati, Breach Candy, and past president of Mumbai Hematology and president of Mumbai Hematology Group. Sir is inspiration for all of us. He has won many awards, including the Inspiring Hematologist of India by Economic Times, and recently Guru Dronacharya Award by Indian Leukemia Academy. So, sir, over to you.
Thank you. Just share my screen. So, good evening to one and all. Today, our guest speaker is Dr. Priyanka Pofle from Wisconsin, USA. She will be speaking to us on what was new in the field of lymphoma in ASH 2023 that is relevant to a clinical hematologist in India. This webinar is brought to you by Mumbai Hematology Group. It is supported by Intas and managed by Perfect Square. I thank Dr. Manoj Kumar and team Intas, Mr. Yash, Mr. Kalpesh in the team Perfect Square, Executive Committee of Mumbai Hematology Group, our guest speaker for the day, Dr. Priyanka Pofle from Wisconsin, US, all our discussants who are themselves eminent hematologists or medical oncologists, you participants for sparing your Saturday evening, morning, or afternoon, depending upon which part of the world you belong to. And we have participation from almost 30 countries today as audience. Tomorrow morning, that's Sunday, 10th March, 11:30 a.m. Indian Standard Time, we have Dr. Hasselback from the Department of Hematology from Denmark speaking to us about treatment of myeloproliferative neoplasms with interferon and how it is changing the whole scenario. Our discussants today are very important personalities from all across India. We have Dr. Aditi Kaskar from Mumbai, Dr. Amit Khurana from Surat, Dr. Anbarasan Sekar from Mumbai, Surgeon Commander Dr. Arun from Mumbai, Dr. Ashwin Nair from Trivandrum, Dr. Vinash Pofle from Nagpur, Dr. Bhausai Bagal from Mumbai, Dr. Chandran Nair from Thalassery, Dr. D.S.K. Sahityam from Vizag, Dr. Deepak Charles from Kochi, Dr. Hamza Dalal from Mumbai, Dr. Hitha from Kozhikode, Dr. Krishna Ratnam from Chennai, Dr. Rifai from Calicut, Dr. Prasanna from Tiruchirappalli, Dr. Rajesh Patil from Mumbai, Dr. Rajkumar Ramaswamy from Madurai, Dr. Ramaswamy NV from Cochin, Dr. Ramesh Balasubramaniam from Madurai, Dr. Subhaprakash Sanyal from Mumbai, and Dr. Thilagavathi from Chennai. It's time to introduce our guest speaker. I don't think she anymore requires introduction to anybody. A couple of months ago, she gave a brilliant talk to us. And in fact, the result of that brilliant talk was instant request from all of you that you want to listen to her as often as possible, as frequently as possible. And I'm grateful to her for accepting this invitation to be with us today at a very short interval after the first one. So brilliant was the presentation and the question and answer session that I'm sure that all of you are going to enjoy whenever she's with us as a speaker and faculty. To complete the formalities, she's assistant professor, lymphoma and CLL, as well as cellular therapy in the Division of Hematology, Oncology and Palliative Care, Department of Medicine, University of Wisconsin Carbone Cancer Center at Wisconsin, US. She received her medical degree from Indira Gandhi Government Medical College, Nagpur, followed by residency in internal medicine at the Cleveland Clinic, followed by fellowship in hematology and medical oncology with advanced training in lymphoma at Mayo Clinic, Rochester. Her areas of expertise are both Hodgkin, non-Hodgkin lymphoma, chronic lymphocytic leukemia, bone marrow transplants, and cellular therapies, including the hot CAR-T. Her clinical research focuses on survivorship, health outcomes, and patient-reported outcomes. She has authored, and this number may be a bit subdued because this is the old CV which I'm reading, 22 peer-reviewed articles, and has been the principal investigator of probably more than 3 clinical trials in addition to multiple conference presentations. I request her to speak on what was new in the field of lymphoma in ASH 2023, which is relevant to the clinical hematologists in India. Thank you, and over to Dr. Priyanka.
Thank you, Dr. Agrawal, for that kind introduction. I hope today's talk lives up to those expectations. I will do my best. Let me share my slides. Okay. Are you seeing the right screen?
Yes.
Okay. So thank you for those of you who joined, and I'm going to review today lymphoma updates from ASH 2023, which happened in San Diego in December. And I will try to focus on things that I think are relevant to hematologists practicing in India, but also give an overview of where the field of lymphoma is headed. These are my disclosures. Because this is ongoing and upcoming research, there is discussion of drugs that are not FDA approved. And the slides, because they are from ASH 2023, are adapted from those presentations. I will review the data presented at ASH 2023 in the context of our current practice in the management of the different subtypes of lymphoma, and also have a couple of abstracts that may be relevant to the general approach and management of lymphoma. So let's start off with Hodgkin lymphoma. When we think of Hodgkin lymphoma patients, our current treatment options are really dictated by the stage at presentation. So if they have limited stage, which is stage 1 to 2A disease, non-bulky, then combined modality treatment with ABVD 2 to 4 cycles and radiation 20 to 30 gray remains the standard of care. And we determine the number of cycles and the dose of radiation based on risk stratification of the limited stage Hodgkin lymphoma into favorable and unfavorable risk categories. There's also the RAPID approach based on the RAPID UK study, which looked at eliminating radiation if patients had limited stage Hodgkin lymphoma and had an interim PET scan that was negative after 3 cycles of ABVD. For advanced stage 2B or bulky stage 3 and 4 Hodgkin lymphoma, ABVD times 6 has been our standard of care for the last many decades, with the RATHL approach of omitting bleomycin if interim PET scan after 2 cycles is negative. And also we have approval from the FDA of using brentuximab vedotin in combination with AVD for 6 cycles based on the Echelon-1 study approved a few years ago. At ASH 2023, the updates we saw in Hodgkin lymphoma included incorporation of these novel agents, brentuximab and nivolumab, in early-stage classic Hodgkin lymphoma, as well as an update from the SWOG S1826 study on the elderly subgroup, which is older than 60 years of age. So if you may have received an update from ASCO 2023, the SWOG S1826 study was a plenary session abstract, which was a randomized controlled trial comparing frontline treatment in advanced stage Hodgkin lymphoma, including pediatric, adult, and older patients, which showed that the progression-free survival just at 1-year follow-up was improved with nivolumab AVD, and the toxicities was much less and better tolerated. So we'll speak about these 2 abstracts today. So the first one, looking at early classical Hodgkin lymphoma. This study was a multi-center, single-arm, open-label phase 2 study which enrolled treatment-naive patients with early-stage non-bulky classical Hodgkin lymphoma. They enrolled 154 patients, and they were treated with a combination of brentuximab vedotin, nivolumab, doxorubicin, and dacarbazine for a total of 4 cycles. Response was assessed at interim after 2 cycles and then at the end of treatment, and the primary endpoint on this study was the complete response rate at the end of treatment. The patients enrolled on this study included ages 18 to 77 with a median age of 31 years, as is expected with Hodgkin lymphoma, and majority had stage 2A disease. The results showed an excellent overall response rate of 98% in the efficacy of evaluable 150 patients, with a CR rate of 93%. The duration of response at 12 months was also 99%. And on the next slide, you will see the progression-free survival at 12 months, which is excellent at 100%. And there were 4 progressive disease events noted in this median follow-up at the time of reporting, which was 16.5 months. So that curve, even though it's very impressive, does need to be taken with a grain of salt, since the median follow-up for this study is short. Early stage Hodgkin lymphoma is cured with our current standard of combined modality treatment or the rapid approach in more than 90% of patients, and longer follow-up will be necessary before this is implemented in practice. There's also ongoing intergroup studies, again, enrolling pediatric and adult patients here in the US, looking at incorporation of BV and Nivo with standard ABVD for early stage Hodgkin lymphoma, and those results will be available in the coming years. The next abstract is the subset of elderly patients from the SWOG S1826 study. So as a reminder, SWOG S1826 was the frontline study which randomized patients with advanced stage Hodgkin lymphoma that were newly diagnosed to either nivolumab in combination with AVD or brentuximab vedotin in combination with AVD for a total of 6 cycles. There was stratification by age, IPS, as well as whether end-of-treatment radiation was intended or not, and the primary endpoint on this study was progression-free survival. The baseline characteristics between the 2 arms were very balanced, and nothing unexpected was noted on the baseline characteristics that are shown here. What was impressive at only median follow-up of a year, the 1-year progression-free survival was 93% on the Nivo-AVD arm versus 64% on the BV-AVD arm. Of course, the overall survival data is not yet mature from this study. And these are the survival curves which indicate the difference in progression-free survival with frontline use of Nivo-AVD in blue compared to BV-AVD in red. And even though this is very exciting data, it is not yet an FDA-approved regimen, but we are hoping it will be approved soon. And I have started using this with patients in clinic, given how much better Nivo-AVD is tolerated. And so coming to the safety data that was presented at ASH from this study, they did see more neutropenia, 53% in patients who received Nivo-AVD compared to 32% in BV-AVD, with the caveat that patients on the Nivo-AVD arm did not mandatorily receive G-CSF support. So only 70% of patients received G-CSF on Nivo-AVD versus 90+% on BV-AVD. They did not see an increased incidence of febrile neutropenia despite the significantly increased difference in neutropenia, and the rate of infections was lower in the Nivo-AVD arm. Peripheral neuropathy, both sensory and motor, as would be expected, was much higher on the BV-AVD arm compared to the Nivo-AVD arm, with more than 2/3 of patients developing peripheral sensory neuropathy and about 15% of patients developing peripheral motor neuropathy in the BV-AVD arm. With regards to lab changes, they did see increase in hypothyroidism in Nivo-AVD occurring in 15% of patients, as well as more rash, but the incidence of other inflammatory side effects such as pneumonitis, gastritis, and hepatitis seem to be comparable in the 2 arms. So my takeaway for Hodgkin lymphoma from ASH 2023 is keep an eye out for incorporation of immunotherapy in the frontline setting, both for advanced stage and early stage classic Hodgkin lymphoma. For advanced stage, the data is more mature and it might be in practice soon. For early stage Hodgkin lymphoma, more information to come in the coming years. For follicular lymphoma, our current frontline treatment options are single-agent rituximab for patients who have low disease burden and low symptom burden versus chemoimmunotherapy with bendamustine and rituximab for patients who have high disease burden meeting the Guelph criteria or have high symptom burden and need rapid relief of symptoms. And then maintenance rituximab is sometimes used depending on the response and other considerations. In the relapse refractory setting, we have numerous options. In the second line setting, our go-to is generally lenalidomide and rituximab based on the relevance trial. And then for patients who have early progression, high-risk follicular lymphoma within 2 years of their initial treatment are considered for more intensive treatments such as autologous stem cell transplant or CAR-T, which are also approved in this space. Bispecific CD20, CD3 directed mosunetuzumab is approved, EZH2 inhibitor tazemetostat is approved, and just this week we have received FDA approval of BTK inhibitor zanubrutinib. PI3 kinase inhibitors, even though they had approval for follicular lymphoma, have been withdrawn from the market with only copanlisib available here in the US, mostly due to unexpected deaths and toxicities due to the PI3 kinase inhibitors. So at ASH 2023, there weren't any major practice-changing updates from follicular lymphoma. There were trials looking at earlier incorporation of bispecifics such as mosunetuzumab and high tumor burden follicular lymphoma, the trial of lysocell, which is generally a more well-tolerated CAR T-cell therapy in follicular lymphoma in the second-line setting in high-risk relapse refractory patients. But the abstract I want to focus on is the long-term efficacy of the 6-month regimen of rituximab and lenalidomide in follicular lymphoma patients in need of first therapy. And this is a Swiss study that was presented at ASH. So this was presented by Professor Emanuel Zucca at the follicular lymphoma session and was updated analysis from the SAC 3510 randomized trial. The aim of this presentation was the analysis of time to event endpoints at a median follow-up of close to 10 years with regards to response duration, time to next therapy, progression-free, and overall survival. This was the study design. They randomized patients 1:1 to either an arm with single-agent rituximab or a combination of rituximab and lenalidomide. And the treatment schedule was slightly different than what is typically used for R-square based on the current FDA approval, with rituximab administered weekly for 4 weeks, week 1 to 4, and then 12 to 15. And on the R-square arm, the lenalidomide was administered 2 weeks prior to the first dose of rituximab and at a constant dose of 15 milligram daily for a total of 6 months. They did stratify patients based on the grade of follicular lymphoma, bulk of disease, and FLIPI score, with first response assessment occurring about 10 weeks after start of treatment. The baseline characteristics on this slide were compared to other large follicular lymphoma studies that have been practice changing, which include PRIMA, Gallium, and Relevance. The Relevance study is what looked at R-square in follicular lymphoma in the relapse setting and enrolled more than 1,000 patients. In comparison to that, I want to draw your attention to the number of patients on the SAC 3510 study were only 154, but the rest of the baseline characteristics such as the grade and the criteria for treatment, median age at diagnosis stage, and high-risk FLIPI enrollment appear to be similar to the other studies. And so I do think that these results can be translated into practice. The primary endpoint on this study showed that the R-square arm had significantly higher overall response rates of 78% compared to 57% at 6 months, with a CR rate at 6 months of 61% versus 36%. With time and longer follow-up, CR rate at 30 months did drop to 42% on the R-square arm compared to close to 20% on the rituximab alone arm. And long-term outcomes appear to be similar, with no change in the progression-free survival, much better on the R-square arm compared to rituximab alone. No differences in overall survival were noted, but the duration of response and time to next treatment were significantly longer in the R-square arm. No unexpected toxicity, but as you would think, combination of lenalidomide with rituximab would cause more neutropenia, more fatigue, more incidences of skin rash, as well as infections, and that was to be expected with this combination. The rate of histologic transformation was noted to be slightly, not histologic transformation alone, but rate of secondary malignancy seemed to be higher on the R-square arm. But again, this was a much smaller study, and the causal relationship is really unclear. So here's just a comparison of the different R-square schedules. The relevant study, which is what is standard practice, gives rituximab once every 4 weeks for 6 cycles, followed by every 8 weeks for 12 cycles. The lenalidomide dosing is 3 out of 4 weeks, 20 milligrams daily, and then drops down to 10 milligrams once the patient has achieved a CR. While this regimen that was presented in this abstract gives rituximab for only a total of 8 doses, every week for the week 1 to 4 and then 12 to 15. And the lenalidomide dosing is 15 milligram daily, continuous for 6 months. And as you can see, the response rates as well as the survival rates are very comparable. And even though 6 years is not a very long follow-up in follicular lymphoma, I think it is adequate to consider this to be practice changing. So this is a promising alternative, particularly where patients are unable to afford treatment with these expensive medications with rituximab and lenalidomide. And it is something that I think can be practice changing in resource-limited settings. Moving on to CLL. Our current treatment options in the frontline setting are determined by whether the patient is interested in continuous treatment with Bruton tyrosine kinase inhibitors, 3 of which, ibrutinib, acalabrutinib, and zanubrutinib, are currently FDA approved, versus a fixed duration approach with venetoclax and obinutuzumab for 12 months. In the relapse refractory setting, the choice of treatment is determined by what the first-line therapy was. And so if patients have a significant duration of remission with frontline venetoclax and obinutuzumab, retreatment can be considered, or switching to one of the BTK inhibitors is an option. If patients receive BTK in the frontline setting, then venetoclax-based treatment in the second-line setting is what is generally used. We also have approval of non-covalent BTK inhibitor pirtobrutinib in the last year or so. And then allogeneic stem cell transplant is an option for young, fit patients who have failed both BTK and venetoclax-based treatment. At ASH 2023, we saw extended follow-up from the ALPINE study, which was a head-to-head comparison of zanubrutinib versus ibrutinib for treatment of relapsed refractory CLL and SLL, and also saw the long-awaited data with longer follow-up with CAR T-cell therapy, liso-cel in relapsed refractory CLL, SLL. We don't yet have FDA approval for commercial CD19 CAR T in the CLL space, and I would like to focus my discussion on the ALPINE study, which was the study of zanubrutinib versus ibrutinib. So just to give a background for those who may not be familiar with BTK inhibitors in CLL and SLL, Bruton tyrosine kinase is an important enzyme in the B-cell receptor signaling pathway that drives proliferation in CLL and SLL. And ibrutinib was the first-in-class covalent BTK inhibitor that was FDA approved first in 2014, so more than a decade ago, for relapsed refractory CLL in the second line and for frontline treatment of patients with deletion 17p high-risk CLL. In 2016, it received a frontline approval for treatment of all CLL, SLL, irrespective of the risk category. But ibrutinib has had high treatment discontinuation rates due to toxicities, which can occur in up to 23% of patients, mostly due to new development of atrial fibrillation or bleeding concerns. And so we now have the second generation covalent BTK inhibitors that have more selective BTK binding and therefore less toxicity, which are acalabrutinib and zanubrutinib. And in the last few years, we have seen these trials comparing head-to-head acalabrutinib versus ibrutinib and then zanubrutinib versus ibrutinib. And so These trials have tried to answer the question with 3 BTK inhibitors available, which is the one we should be preferentially using for CLL/SLL. So the initial results from the Alpine phase 3 randomized study were presented at ASH in 2022, and this was the study design. Patients with CLL/SLL who had relapsed after 1 prior line of treatment were included as long as they had measurable disease and prior BTK inhibitor therapy was an exclusionary criteria, as well as any patients on treatment with drugs that could interact with BTK inhibitors, such as warfarin and increased bleeding risk, were not allowed. Patients were randomized 1:1 to zanubrutinib 160 mg BID versus ibrutinib 420 mg daily, and this was a continuous treatment until disease progression or unacceptable toxicity. The primary endpoint on the study was overall response rate, and it was designed as a non-inferiority as well as superiority study from a statistical standpoint with 625 patients randomized. The demographics in these 2 arms were balanced and are shown in brief here, with 23% patients with del17p or p53 mutations and 73% with unmutated IGHV. More than 90% were in the second line, as would be expected. At last follow-up, more patients remained on treatment with the zanubrutinib compared to ibrutinib, with more discontinuations of ibrutinib, both due to toxicity as well as due to progressive disease. And at ASH 2023, we saw a longer follow-up, median of 36.3 months on the Alpine study, still showing a significantly different progression-free survival, 65.8% on the zanubrutinib arm and 54.3% on the ibrutinib arm. In addition, in terms of toxicity, zanubrutinib remained better tolerated compared to ibrutinib, with fewer adverse events leading to treatment discontinuation. Here I have the table from the abstract looking at cardiac adverse events, which were noted in 23% of patients with zanubrutinib and 33% in ibrutinib, which doesn't seem like a big difference. But if you look at serious cardiac adverse events, 9.6% with ibrutinib versus 3.1% with zanubrutinib, including 1.9% or 6 cardiac deaths on the ibrutinib arm. Atrial fibrillation incidence was also much higher, 16% on ibrutinib versus 6.2% on zanubrutinib. And so it is very clear that from a cardiac safety standpoint, zanubrutinib is the safer drug. And I do think this is something I've incorporated in practice, and I have started using more zanubrutinib and acalabrutinib over ibrutinib, given the better safety profile, and now also improved progression-free survival with zanubrutinib. Moving on to the next lymphoma subtype, which is mantle cell lymphoma. And mantle cell lymphoma is a disease where the standard of care is not very clear-cut, and it is rapidly evolving. In the frontline setting, chemoimmunotherapy remains the standard of care, as we don't yet have approval of targeted agents in the frontline setting. For younger, fitter patients, cytarabine-based Nordic regimen, the more intensive treatment is preferred, versus for older patients, bendamustine and rituximab is a good choice for chemoimmunotherapy. Consolidative autologous stem cell transplant in first remission also remains the standard of care, but is being questioned in many clinical trials, some of which have been presented over the last few years. And we will likely be moving to a more response-directed treatment based on MRD and response to initial chemoimmunotherapy on whether autologous stem cell transplant will be recommended or not, but more mature data from those studies is still awaited. Maintenance rituximab is very important to consider in mantle cell lymphoma, both for patients who receive frontline chemoimmunotherapy as well as those who undergo autologous stem cell transplant, as it improves not just progression-free, but overall survival. In the relapse setting, I think it is very clear that Bruton tyrosine kinase inhibitor are the standard of care in the second line. And we have acalabrutinib and zanubrutinib, with the FDA withdrawing the approval of ibrutinib due to toxicity, and it was a provisional or conditional approval for mantle cell. In the third line setting, for patients who are CAR-T eligible, we have Tecartus or brexucabtagene maraleucel as a treatment option, as well as the approval of non-covalent BTK inhibitor pirtobrutinib in the last year, and older agents such as bortezomib, lenalidomide can be considered, as well as venetoclax, which doesn't have an FDA label for mantle cell lymphoma. At ASH 2023, We saw results from frontline and relapsed mantle cell lymphoma studies looking at combination of BTK inhibitors with BCL2 inhibitor, venetoclax, as well as obinutuzumab. And I will caution that these studies are not yet ready for prime time, but important to be aware of, as we will likely be moving to chemotherapy-free regimens in mantle cell lymphoma in the coming years. So I'll start with the bovine study, and this was significant because it selectively enrolled very high-risk mantle cell lymphoma patients who had TP53 mutations in the frontline setting. And we know that these patients have a poor progression-free survival of less than a year with chemoimmunotherapy. And so this study looked at incorporating zanubrutinib, obinutuzumab, and venetoclax, called the bovine regimen, for these treatment-naive high-risk patients. So here's the study schema. It was a single-arm phase 2 trial, and given selective enrollment of high-risk patients, their enrollment goal was only 25 patients. So again, important to remember, very small study. The study gave patients zanubrutinib, 160 milligrams twice a day in combination with obinutuzumab starting cycle 1, day 1. And then venetoclax was added at cycle 3 with a 5-week gradual ramp up to the goal dose of 400 milligram daily. The plan for treatment was 24 cycles, and then MRD testing was performed. If patients were in a complete remission and with undetectable MRD, then treatment was stopped, versus if they did not achieve a CR or had detectable MRD, then they would continue treatment with the 2 oral agents, zanubrutinib and venetoclax. The primary endpoint on the study was 2-year PFS, and the way they had designed the study, treatment was considered to be effective if more than 11 patients were progression-free at 2 years, knowing that the progression-free survival for this group with chemotherapy is less than a year. The response on the study was excellent, with overall response rate being 96%, and response after just 2 cycles of zanubrutinib and obinutuzumab being 76% with 68% CRs. So we did see deepening of response as well as more responses with the addition of venetoclax to zanubrutinib and obinutuzumab. There were some events noted on the study, including 5 progressive disease and 4 deaths that occurred due to infection with ongoing responses. The progression-free survival at 2 years on this study was 72%, which is remarkable for this high-risk group again. And they did meet the primary endpoint with 11 patients being progression-free at 2 years. There were no significant associations between disease-free survival and baseline features, including disease morphology, Ki67, or whether it was mono or biallelic TP53 inactivation. Let's talk about the other combination study, which was the Simpatico trial, which was a late-breaking abstract at ASH presented by Dr. Michael Wong. This study enrolled patients with relapsed refractory mantle cell lymphoma who had received 1 to 5 prior treatments, including an anti-CD20 monoclonal antibody, but did not allow patients who had received prior BTK or BCL2 inhibitors. It was a randomized, double-blind, placebo-controlled phase 3 study, so overall very well done, with ibrutinib venetoclax being one arm and ibrutinib placebo being the other arm. At 2 years, venetoclax or placebo would be discontinued, but the ibrutinib will be continued indefinitely until progressive disease or unacceptable toxicity. And the primary endpoint on this study was progression-free survival by investigator assessment. The baseline characteristics are no different than would be expected in a relapsed refractory mantle cell study, but majority of patients, about 60%, had only 1 prior line of treatment, and 16% of patients with 3 or more prior lines of treatment. The TP53 mutated status was present in 30% of patients enrolled on both arms. The results showed a significantly higher median progression-free survival of 31.9 months on the combination ibrutinib-venetoclax arm versus 22.1 months on the ibrutinib placebo arm. Irrespective of how the data was looked at, the progression-free survival was longer on the ibrutinib-venetoclax arm. The median duration of treatment also seemed to be longer, with 22.2 months on the ibrutinib-venetoclax arm and 17 months on the ibrutinib placebo arm, and this is a little hard to explain. This is the Kaplan-Meier curve showing the same difference in progression-free survival with the combination ibrutinib-venetoclax in blue and ibrutinib placebo in yellow. In terms of adverse events, as would be expected, the combination did have more adverse events, with grade 3 or higher toxicity being 84% on the combination arm versus 76% on the ibrutinib placebo arm. But the rate of serious adverse events was similar, rate of discontinuation of drugs was similar, dose reductions were more likely to happen on the combination arm compared to the ibrutinib placebo arm. Other adverse events that were higher on the combination included diarrhea, neutropenia, nausea. However, risk of fatigue and fevers were similar across the two arms. Let's change gears now and move to another subtype of lymphoma, the most common, which is diffuse large B-cell lymphoma. And our current frontline treatment approach for diffuse large B-cell lymphoma includes R-CHOP, which has been the standard of care for the last many decades. And we also now have approval of the novel agent polatuzumab vedotin, which is an antibody drug conjugate targeting CD79B in combination with rituximab and CHP with the omission of vincristine. And this approval was based on the POLARIX trial, which was a phase 3 randomized study that showed an improvement in progression-free survival about 6% with the POLA R-CHIP arm compared to R-CHOP, and no difference in toxicity. In the relapse setting, our approach to DLBCL has become pretty complex, with patients who have an early relapse within 12 months of initial treatment or primary refractory disease or relapse after an autologous stem cell transplant receiving CAR-T as the standard of care. And we have 3 products approved depending on whether it is second line or third line treatment. If patients have a late relapse beyond 12 months, we still use chemo in the second line setting, followed by autologous stem cell transplant if they have chemosensitive disease versus CAR-T if they have chemorefractory disease. But for patients who are not candidates for intensive treatment, we do have polatuzumab vedotin in combination with bendamustine rituximab, as well as CD19 antibody tafasitamab in combination with lenalidomide that are treatment options. Relapse for more than the second time or beyond, we can use the agents that they may not have received previously at first relapse, but also have specific approvals with loncastuximab tesirine, which is an antibody drug conjugate directed to CD19, as well as bispecifics epcoritamab and glofitamab directed against CD20 and CD3, which have been approved in the last year. And selinexor is an oral agent that has FDA approval, but is rarely used now with so many treatment options available to us. Some other updates that have occurred in the last few years have taught us about the biology of DLBCL, that the cell of origin by Hans algorithm may not be as accurate as using other methods. LymphGen classification based on whole exome sequencing, as well as DLBCL clusters based on RNA-seq, have taught us that there's more complexity for diffuse large B-cell lymphoma than can be currently detected in the clinic based on the HemePath Hans algorithm available to most clinics. The WHO also updated their classification with the 5th edition, and the main one I think to note is that high-grade B-cell lymphoma with MYC and BCL6 rearrangements, which is the BCL6 double hit, was removed from the high-grade B-cell lymphoma category and moved to the DLBCL NOS category. So the only high-grade or double hit lymphoma that matters is with MYC and BCL2 gene rearrangements alone, or triple hit, where you have MYC, BCL2, and BCL6. So at ASH 2023, there weren't any great practice-changing updates when it comes to management of diffuse large B-cell lymphoma, but there was retrospective data presented by Dr. Khurana from the Mayo Clinic showing better outcomes for BCL6 double-hit lymphoma compared to BCL2 double-hit lymphoma, which supports the reclassification of BCL6 double-hit in the new WHO edition with DLBCL-NOS. We also saw updates from the POLARIX trial based on the genetic subtypes of DLBCL by whole exome and RNA-seq versus nanostring cell of origin. And again, since these technologies are not available in clinic, we don't necessarily discriminate on who should receive frontline polatuzumab, rituximab, CHP, as long as they meet the FDA approval. For relapsed refractory DLBCL, we saw lots of combination phase 2 studies with bispecifics, with chemotherapy, other agents, as well as updated data from the CAR-T trials. But the one abstract that I want to focus on, which was a theme of ASH 2023, was circulating tumor DNA. And I'm hopeful that this is going to be practice changing, not at the moment, but hopefully in the coming years. So there were many abstracts presented looking at minimal residual disease in DLBCL, also looking at cell-free DNA as a marker for earlier detection of CNS relapse or CSF staging at diagnosis. But the study we'll talk about is a prospective real-world circulating tumor DNA study for patients treated in frontline setting with curative intent treatment. So this study enrolled patients with stage 1 to 4 DLBCL undergoing treatment with frontline R-CHOP or R-EPOCH, and they collected blood for circulating tumor DNA profiling at baseline, interim after 3 cycles, and then at the end of treatment. The ctDNA MRD testing was using this phased seq technique offered by Foresight Diagnostics. And patients were included in the analysis as long as they had baseline samples as well as follow-up samples, and 99 patients were evaluable from this study. So ctDNA outperformed PET scan for response assessment when they looked at the predictive value at the end of therapy. The Kaplan-Meier curve on the top shows overall survival stratification by whether a PET complete response was achieved, which is the blue, versus PET complete response was not achieved at the end of treatment. And you can see that PET is definitely discriminatory and is our current standard of care at the end of treatment for DLBCL. However, what was interesting was that circulating tumor DNA had a better discriminatory power when it came to patients who were ctDNA negative in blue versus those who were ctDNA positive in red. And in the interest of time, I think I'm going to skip through some of these slides, which showed that circulating tumor DNA generally outperformed PET scan, both at interim and end of treatment time points. And even in patients who were PET positive, ctDNA was better in terms of predicting outcomes, as well as patients who had PET CT at the end of treatment negative, circulating tumor DNA was predictive of outcome. And I think this is the takeaway, that circulating tumor DNA predicted outcome when we had discordant results with the PET scan at the end of treatment, meaning patients who had a positive PET and negative MRD, or a negative PET and a positive MRD, it seemed that the circulating tumor DNA was more reliable. And this is important for patients with a positive PET because they often undergo more biopsies or follow-up scans and significant distress, worrying about disease relapse. And patients who have a negative PET may sometimes be falsely reassured that they are cured when their disease is likely to relapse if they are circulating tumor DNA positive. And so I'm hopeful that this very practical tool of circulating tumor DNA, which is really a blood test that is needed to determine outcomes at the end of treatment, comes into practice soon so that we can better discriminate and also educate our patients about what their risk is, and also avoid unnecessary follow-up and anxiety. We have a few general updates that I want to cover, which I thought were things that were important and things that would change my practice in clinic. To start, I'll talk about a randomized study which looked at post-dural puncture headaches with the use of atraumatic needles in hematology. And this was presented at a lymphoma session, even though it included patients with ALL. And I do think we use enough lumbar punctures and intrathecal chemotherapy in the lymphoma world where this is relevant to this talk. So this was a randomized study aiming at evaluating the incidence of post-dural puncture headache with the use of atraumatic needles in hematology. And there is significant data, including large systematic reviews and meta-analysis that have shown that atraumatic needles in general for lumbar puncture are better, but I don't think we've adopted this in our practice in hematology. And this is the figure on the right that shows what a cutting or traumatic needle looks like, where you have a beveled end and the opening in the front, versus an atraumatic needle, which is pointed in the and sharp in the front, but has the opening on the side. And just to summarize why this study was done, because post-dural puncture headache is the most common complication of lumbar puncture due to CSF leakage, significantly impacts quality of life, requires patient follow-up, prescription of pain medication, sometimes additional procedures such as blood patching. And so this was a double-blind study that randomized 68 patients to either a cutting needle versus an atraumatic needle. And the outcome they were looking at was occurrence of severe headache. The overall rate of severe post-dural puncture headaches was close to 20%, which is definitely 1 in 5 patients had a severe post-dural puncture headache. But the incidence of this was significantly different. In the conventional needle group, it was 31% of patients. So 1 in 3 patients had a severe headache versus only 6.5% in the atraumatic group. In addition, they showed that the first attempt of LP success, failure rate, mean number of attempts, and the frequency of analgesic prescriptions did not differ between the 2 needle groups. And the graphic here shows the severe headaches in red versus the less severe headaches in green, and you can see the traumatic needle has more red compared to the atraumatic needle. And so this is something I'm trying to incorporate and change practice here at our institution, and hopefully can be something that you can incorporate in your clinic. The second study, I think, is very important because it looks at predicting toxicities in older adults with non-Hodgkin lymphoma receiving frontline systemic therapy. And this was a prospective geriatric assessment study that was presented by Dr. Pallavi Turka at one of the oral abstract sessions. This is important because a majority of non-Hodgkin lymphoma patients are older, and we know that toxicity increases with age. Reduced intensity treatments, such as using regimens without anthracyclines or using our mini-CHOP as the frontline regimen based on age, is associated with poor disease outcomes. And so we cannot use chronologic age as the criteria for choosing the intensity of treatment. However, most geriatric assessment tools, as I will show you soon, are cumbersome, complicated, and very hard to implement in our time-limited and resource-limited clinics. So this was a single institution prospective study from the Memorial Sloan Kettering enrolling patients older than 60 with non-Hodgkin lymphoma starting frontline chemoimmunotherapy, and they looked at different geriatric assessments at baseline as well as longitudinally. The geriatric instruments are many, and they look at various domains of functional status, comorbidity, psychological state, cognition, social activity, social support, nutrition, polypharmacy. And so just this list is long, and the tools themselves take many minutes or sometimes hours to actually go through with the patient. But the one that was interesting was this timed up and go test, which is easy to implement in clinic and is considered impaired if it takes more than 12 seconds to complete. So the primary endpoint on this study was a toxicity event, which was defined as hospitalization within 30 days following chemotherapy, a dose delay or dose reduction in intensity to less than 80% of planned, and discontinuation due to chemotherapy toxicity or death during treatment. And the study enrolled majority diffuse large B-cell lymphoma, advanced stage patients treated with R-CHOP and had a median follow-up of 4.3 years. And what they showed was this timed up and go test was independently associated with toxicity in their multivariate analysis. The outcomes on this prospective study were good, with median overall survival probability at 2 years being 81%. And there were numerous other components of their assessments associated with overall survival, but only the TUG was independently associated with toxicity. And what is this timed up and go test? It is really just as the name suggests, timing of how long it takes for the patient to get up and go. So it involves starting from sitting to stand as step one, walking 3 meters in a straight line, turning around, walking back 3 meters, and sitting down with someone timing that. And if it is longer than 12 seconds, then that patient is at increased risk of toxicity and may benefit from decreased intensity. But at the same time, if you have an 80-year-old who maybe looks otherwise fit and has a timed up and go that is less than 12 seconds, maybe you still want to attempt intensive or more full dose treatment at the beginning before reducing dose just based on age. So with that, I think my take-home messages from ASH 2023 in Hodgkin lymphoma were that Nivo-AVD is poised to become the frontline standard of care for advanced stage and will be looked at in early limited stage disease as well. Follicular lymphoma, shorter duration of R-square may be as effective and promising. And I think this is one of the more practice-changing abstracts that I discussed today. For CLL, zanubrutinib is more efficacious and safer than ibrutinib, shown even with longer follow-up. No more adverse events were noted. In mantle cell lymphoma, combinations with BTK inhibitors or chemotherapy-free combinations look very promising for both high-risk patients as well as for achieving deeper MRD-negative remissions. For diffuse large B-cell lymphoma, circulating DNA may have more predictive value than the end-of-treatment PET scan and hopefully will be coming to practice soon. But the TUG, or the timed up and go, is something we can all incorporate into our practice right away. And with that, I will end and take any questions, comments, or other discussion points from ASH 23.
Was fantastic.
So, good evening, Dr. Priyanka. It was excellent presentation.
Yeah, so we now take up questions. Dr. Krishnarathan.
Okay, thank you very much for an excellent educative session, bringing us up to date. I have a practical real-life question. If you have a patient who has got a high-risk, NHL, high-grade NHL, double hit or triple hit, and he has not responded satisfactorily to the first-line therapy, say primary resistant, and he has got residual disease after the first round of chemotherapy, how would you approach, if you have all the options in front of you, who is primarily resistant, a high-grade NHL, or a double hit or a triple hit, who has not responded to the first line, how would you approach if you have all the options in front of you, like bispecifics, polatuzumab, or CAR T therapy?
Yeah. So if I have all the options and I'm practicing where I'm at right now in the US, then I will be moving this patient to second-line treatment with CAR T. I will say for patients who have double hit or high-grade B-cell lymphoma, most of the time I am intensifying treatment with dose-adjusted EPOC compared to R-CHOP, since we know that R-CHOP has inferior outcomes in these patients. Second-line CAR T is also challenging if they have very rapidly progressive disease, and we often have to use some sort of bridging. And depending on the disease burden, I've sometimes used traditional chemotherapies such as RGDP or ICE because they need treatment quickly, and getting the novel agents approved can be time consuming from the insurance standpoint, and the disease is progressing very quickly in a matter of days. So I admit the patient, give them like old chemotherapy like our ICE. while I am waiting for their CAR T cells to be made. If the patient is stable and not rapidly progressive, then I've used polatuzumab-based regimens in the second line while I try to get the patient to CAR T. If you don't have access to CAR T cell therapy or these novel agents, then I think using other gemcitabine-based or like ifosfamide platinum-based regimens is probably the next step. And there may be a small proportion who respond who could benefit from an autologous stem cell transplant. But in my current practice, with everything available, I think CAR T in the second line is the way to go. And I've had patients even blow through CAR T, and then I've used bispecific, some with positive response, some without. And many times we're not able to overcome the bad biology of the disease.
Thank you. Just one more question, if I'm permitted. In case the patient responds to the second line therapy, would you go to the autologous transplant pathway, or still you can go for a CAR T?
So I think with bad biology, I prefer using CAR T, even if they respond really well and achieve a CR to second line treatment, because that CR is unlikely to be sustained, and more chemo, which is basically what autologous stem cell transplant is unlikely to give us a sustained remission. So I would still take the patient to CAR T, but what the studies show us from the second line CAR T is that there is a small proportion, less than 30%, who, if they go to an autologous stem cell transplant, could still be cured. So I don't think you would be wrong if they achieve a CR to take them to an auto transplant as the first step. But for these primary refractory patients, my experience has been they blow through autologous stem cell transplant. So it's like the disease progresses before the patient recovers from the side effects of the transplant. And then when they are feeling, so poorly, you have to kind of talk to them about CAR T, which is another intensive treatment. And it is a very hard space to navigate. So my preference would always be CAR T in primary refractory patients rather than attempting an autologous stem cell transplant and waiting for it to fail.
Thank you very much.
Thank you, Dr. Krishnaratnam. One question from the audience, and that's related to double hit lymphoma. Do you treat them differently? And the second part of the question is CNS prophylaxis required for this subset?
Yeah. So both answers in short are yes. For double hit, which now I consider only BCL2 double hit or triple hits with BCL2 and BCL6 in addition to MYC, I do intensify treatment to dose-adjusted EPOC in most circumstances if the patient can tolerate it. If it is an older patient, instead of doing mini CHOP, I try to do full dose CHOP, which will be an intensive regimen for someone who is 80. And so, yes, I am treating them more intensely because we know that our current treatments are not good enough. Now, on the other hand, with the availability of polatuzumab, I have not yet treated a double hit patient with Pola or CHIP, and that may be an option to consider if I feel dose-adjusted EPOC is going to be poorly tolerated, then incorporation of Pola might be helpful, although the double hit subgroup on the POLARIX study was small, and we don't convincingly know yet that it is better in that specific subgroup. And to the second part of the question, for these patients, I follow the protocol. So dose-adjusted EPOC has intrathecal chemotherapy built in. So I do give intrathecal chemotherapy for these patients. If I'm doing R-CHOP, I don't necessarily add high-dose methotrexate prophylaxis because I think overall the data for CNS prophylaxis is less convincing, and it's more important to not delay their systemic treatment moving forward.
Thank you. Before we ask Dr. Ramesh to ask a question, can I ask one question? Whether Pola R-CHIP has become the standard of care in US already, or if the word is divided?
Depends on who you ask. So I think it is FDA approved, so it is accessible to our patients. I typically use it for very high-risk patients, ABC subtype, a high-grade B cell where I cannot use EPOC. So I'm being selective in my approach to applying it, but the purists will say that you should give it to everybody who is eligible for the study, meaning IPI2 or higher with DLBCL. So I think we don't have a uniform approach, but it is available to our patients. And so you're not incorrect in either approach.
All right. Thank you. Ramesh.
Thank you, sir, for the opportunity. It was an excellent presentation, ma'am. I have a couple of questions. My first question is in ABC type of DLBCL, like addition of any newer agent to the standard R-CHOP, will it be beneficial, like adding a BTK inhibitor or venetoclax to the R-CHOP? Will it be beneficial or R-CHOP?
So right now, we are not adding any of those agents, but I think it is appropriate to consider it, especially ibrutinib or venetoclax for younger patients in the ABC subtype in particular may have some progression-free survival benefit, but I will add that it also adds significant toxicity. With venetoclax, the cytopenias are much worse. So I think the one situation where I've used it is like Richter's transformation, where we are needing to combine targeted agent with chemotherapy because the CLL has now transformed. And it is very challenging to give venetoclax with R-CHOP because it causes more cytopenias. I think considering it is not wrong, but I think polatuzumab might be a better option to use because it doesn't add to the toxicity based on the POLARIX study. And there have been some analysis pooling data from the different polatuzumab studies like POLA-BR, POLA-R-CHP, which seem to suggest that the ABC subtype is where the most benefit from polatuzumab is. So if you have access to polatuzumab and you have an ABC subtype that you're worried about, I would consider POLA rather than these oral targeted agents, which can add to the toxicity.
Okay. My second question is in follicular lymphoma. We have a patient of follicular lymphoma, young age, around 45 years, male patient. After first line therapy, he was on maintenance rituximab, and he has relapsed after relapsed while he was on rituximab maintenance. And he was treated with salvage chemo, GDP, RGDP, and he has a persistent disease in adrenal. And whether if you are given rituximab or lenalidomide, will it have been better when compared to the salvage chemo, or the results comparing the len rituximab versus salvage chemo in relapsed follicular lymphoma?
Yeah, no, I am not aware that there's any head-to-head comparison of salvage chemotherapy with lenalidomide and rituximab. But in this patient, if he has already failed salvage, I think changing the approach to targeted agents is a good idea. What I could suggest here is trying to use lenalidomide with obinutuzumab, because we know that obinutuzumab is a better or stronger anti-CD20 compared to rituximab, even in follicular lymphoma. And so when patients progress while on rituximab maintenance, often switching the anti-CD20 itself can have a good impact. So either if you're still using chemo, then using obina with the chemotherapy regimen, or using obina with lenalidomide if that's going to be your next step.
Should we consider intrathecal prophylaxis in this patient, ma'am? Because he has got an adrenal lesion, like in DLBCL, we consider it as a risk for CNS involvement. Should we extrapolate it to the same in follicular?
Yeah, I wouldn't, because indolent lymphomas going to the CNS is even lower than DLBCL. In DLBCL, the incidence of CNS involvement is about 10% over the course of the patient's life. So we're talking about very little to gain from the CNS prophylaxis. And I think you deal with it if it happens, but it is more likely to not happen than happen even with adrenal involvement in follicular lymphoma. So I would avoid it.
My last question, like in relapsed Hodgkin lymphoma, with if the novel agents are not available, like where do you place the bendamustine lenalidomide as a treatment option?
Yeah,
because a few patients have got very good results with benda and len who are refractory to multiple agents, who are refractory even after autologous transplant for progress. Bendamustine lenalidomide has given partial response to near complete response in some of the patients.
Yeah, that's interesting to hear. I have not used the bendamustine lenalidomide regimen, so I don't want to speak for it. But I do think that there are patients with Hodgkin lymphoma who also benefit from a more targeted agent rather than hitting them with chemo approach. And lenalidomide is an agent. Everolimus is an agent that sometimes has effectiveness in Hodgkin lymphoma. And so I'm glad your patient is responding. And if there's not much data out there, maybe something to publish.
Thank you.
Thank you, Ramesh. Once again, before going to Aditi, Dr. Priyanka, I'll ask one question about back to Hodgkin lymphoma. Your views on Bricard, the brentuximab card. That
I am not familiar with that regimen. Brentuximab card?
Brentuximab vedotin, and then you have adriamycin, dacarbazine, dexamethasone, etoposide. That means the BACOP is sort of reduced with respect to its toxicity, and you add brentuximab.
Oh, yes, I think I saw this data at one of the meetings, but I haven't particularly used this regimen. I worry about toxicity just hearing that combination because brentuximab is not an easy drug to give, even in combination with AVD, which is how I was using it before, switching to Nivo AVD recently. It is a very hard to tolerate regimen in terms of neutropenia, neutropenic complications, peripheral neuropathy. And so just hearing the drugs in there, including the etoposide, I mean, unless you have like a very young 20, 30-year-old where you want to attempt to use it and they have very high risk disease, I think it's fair game since there's data to support it. But I would be very cautious of toxicity just with the drugs that you mentioned.
Sure. Aditi, your question.
Thank you. It was a wonderful talk. So I want to discuss two cases. One is a young male, 35-year-old, known case of follicular lymphoma, diagnosed 5 years back. He was grade 3A. So he was treated with R-CHOP elsewhere in remission for 5 years. And now he's got a chest wall swelling. Otherwise, PET is awaited and the chest wall is again showing follicular grade 3. So after doing the PET scan, what would you suggest if the PET scan is negative or if the PET scan shows, say, stage 3 or 4 disease?
Yeah, I would definitely biopsy again because, 3A
Biopsy is done again. Biopsy
again, it's 3A?
Yeah, 3.
Okay. So, I mean, the patient has not received bendamustine. So that's an option for time-limited treatment where you could use bendamustine and rituximab as a treatment option. You could use lenalidomide rituximab, and the data I showed would support a shorter course of 6 months, could also give him a lasting remission. I mean, the patient is young, so he's going to go through a lot of treatments for follicular in his lifetime. But with a remission that lasted more than 5 years, I'm less inclined to consider salvage and auto in this patient because he likely has a good behaving disease. So I think DR versus R square is what I would consider here.
So no autologous when the first remission is for more than 5 years. Okay.
Correct.
And second patient is an elderly 72-year-old CLL. The CLL had not progressed, but now developed a new node, and the node is DLBCL. And PET is stage 3. So started on R-mini-CHOP. He's 72 or 73. Post R-mini-CHOP, planning to start on ibrutinib. Do you have any views or any different opinion for this?
No, I think that sounds like a reasonable approach. If he achieves a complete remission with R-mini-CHOP, I mean, sometimes you already gave him R-mini-CHOP, and that tells me that he's probably not a candidate for autologous stem cell transplant, which is something that we use in Richter's transformation because we don't have great options. But I think the approach of using ibrutinib as maintenance or for the underlying CLL is a good one and hopefully will prevent further disease progression. So yeah, I have nothing to add.
So based on this Richter's transformation, ideally DLBCL in young, they say upfront allogenic. So, and the CLL, as I said, was not progressing since 2 years. How much will ibrutinib help in the PFS of the Richter's transformation, that is the DLBCL?
So in patients who have untreated underlying CLL, which is this patient's situation, the Richter's transformation generally is better in terms of progression-free survival versus someone who has had multiply treated and relapsed CLL and then transforms to Richter's. That's a much worse disease biology. I can't quote from the top of my head the data for using ibrutinib in a CR and when a patient with CLL has never required treatment. But I think the approach is correct because you are trying to avoid recurrence of both the Richter's transformation as well as progression of the CLL, even though the patient hasn't needed treatment right now. So I think I agree with your approach. I don't know what to quote in terms of numbers.
Thank you. And one last basic question. In DLBCL upfront, do you all do bone marrow examination, even if PET is not showing any uptake? And early stage versus stage 3, stage 4?
Yeah, good question. So for advanced stage, no role of doing a bone marrow biopsy. In limited stage, it kind of depends. So if I have a limited stage bulky where I'm planning to do 6 cycles of R-CHOP anyways, then I don't think that the bone marrow changes my approach. So I'm not going to do the bone marrow biopsy, and a PET is sensitive to detect bone marrow involvement. The only time I do a bone marrow biopsy is if I have limited stage disease. I'm trying to use the flyer approach and give like shorter course of R-CHOP in those patients, or do like 3 cycles of R-CHOP with radiation. I want to know with certainty that the patient does not have bone marrow involvement with DLBCL, and also if there's a concurrent indolent lymphoma, which might help me counsel the patient about the chances of recurrence of the indolent component, even if the DLBCL achieves a remission. So for limited stage patients being treated with abbreviated treatment, I will do a bone marrow despite a negative PET, but in all other circumstances, I'm not doing a bone marrow biopsy.
Okay, thank you so much.
Thank you. Dr. Priyanka, Aditi's first patient of Richter, will CAR-T will be your preference?
So I think it's hard to get CAR-T approved without relapse of the Richters. So I think in the frontline setting for Richters, I wouldn't do CAR-T. And I also didn't address her questions about allo transplant. So our approach really has, and again, there's not a lot of data for Richter since it's such a rare thing. For patients who have underlying CLL that is untreated with Richters, we use autologous stem cell transplant consolidation for the Richter's portion. For patients who have active CLL on treatment and have a Richter's, and if they're candidates for allo, then allo would kind of get at both things. But I don't think you're wrong to do an allogeneic stem cell transplant for a young, healthy patient with Richter's and no prior CLL treatment, because the allo could be curative from a CLL perspective as well. But yeah, CAR-T in Richter's, we've used it only when it is meeting like the criteria of early relapse or primary refractory Richter's, because we can't obviously use it in the frontline setting.
And for follicular grade 3B, what is your approach?
Depends. I think overall, I tend to decide based on disease burden, as well as how much, like if the PET scan shows one spot that is bright and the rest of it looks like follicular versus all of it looks like it's more likely to be transformed. I generally use more R-CHOP for stage or follicular grade 3B rather than using bendamustine based regimens, because the concern it has a more DLBCL like behavior.
Thank you. Dr. Sahitya?
Hello. Ma'am, I have a few questions. In relapsed refractory Hodgkin's, what is your go-to approach? Do you consider BV or Nivo-Pembro based regimens?
I think both. With immunotherapy looking so promising, I think I always incorporate a checkpoint inhibitor now. And over the short term, when we're talking about doing just 2 cycles of salvage and getting them to an auto transplant, I think the side effects from the hypothyroidism and immune related side effects are very less likely to happen in the second line setting. So I always use an immunotherapy based regimen. Whether I combine it with traditional chemo like Nivo ICE or Pembro GVT versus doing like Nivo BV combination kind of depends on how much disease burden there is and what frontline regimen they receive. So obviously, if they receive BV frontline, I'm not going to use it in the second line setting. But if they received ABVD frontline and have low disease burden, sometimes I do checkpoint inhibitor alone or checkpoint in combination with BV. But if they have high disease burden, then I usually combine chemotherapy with checkpoint inhibitor therapy.
And routinely, like in first-line Hodgkin's treatment, if your interim PET is positive, how many percentage of patients do you escalate to BCOP?
This is a US versus Europe question. And so where I practice, we don't escalate to be a cop. In those cases, generally depending on the response, like if it is improved but not completely gone, then I would continue the regimen that they are on and repeat a PET scan again after 2 more cycles. And if they have progressive disease, then treat them as primary refractory and try to take them to an auto with salvage. But I think be a cop is an appropriate approach. There's data for escalation for PET positive positive patients. I just don't do it in practice, but I think we will be, because we are opening the limited stage Hodgkin lymphoma study, and on the clinical trial, you have to escalate if you are interim PET positive. So I will get some more experience with that.
Okay. And my third question is, in elderly Hodgkins who have relapsed, what is your go-to regimen?
Elderly Hodgkins, not auto candidates. I would either use checkpoint inhibitor alone and try to do like a maintenance if they respond to it, or I would use checkpoint inhibitor in combination with brentuximab vedotin. But the brentuximab vedotin I will only continue till they achieve a response, and then for maintenance I'll continue just the checkpoint inhibitor.
And the last question, do you routinely do a bone marrow for assessing response if your PET is clear at DLBCL after giving induction with 6 cycles?
No.
We recently had a case where PET was negative and he relapsed after 2 months in the bone marrow. So I was just wondering if PET was in CMR, but yeah, bone marrow showed persistent of disease.
And I think it depends. So if this is a patient who had disease in the bone marrow at diagnosis or had significant cytopenias in the beginning, even before starting treatment, that made you worry about bone marrow diagnosis, even though the PET was negative, then I think reassessing response with a bone marrow at the end of treatment is reasonable to do. But data I showed you clearly says that PET is imperfect, right? Like patients with a negative PET scan, still 20% can have relapses after. And that's why we need better tools to confirm that remission at the end of treatment.
Thank you, ma'am.
Sahit, when you are using Nevo in the setting of second, third line, rather third line, it is an endless process. You just continue. The duration.
Maintenance.
Yeah. Yes, if they're not getting an autologous stem cell transplant, then basically we continue as long as it works.
Till he relapses.
Yeah.
Dr. Amit?
Yeah, thank you for that wonderful talk. I have a similar question on follicular lymphoma as Dr. Ramesh and Dr. Aditi asked. I had a case of 35 years female, grade 3B follicular lymphoma, relapsing within 6 months and presenting with CNS involvement, treated with R-CHOP frontline. How would you go about this case?
Yeah, I think secondary CNS relapse is very complicated and concerning. If there is no evidence of systemic disease, then I would approach this like you would a primary CNS lymphoma. So use a methotrexate-based regimen, like MTR is what our standard is, but you can use other regimens like Matrix. And then once they achieve a remission, I would take them to an autologous stem cell transplant with a thiotepa-based regimen. I think this follicular 3B is behaving like a diffuse large B-cell lymphoma, including the CNS relapse. So that would be my approach. It becomes very hard if they have both systemic and CNS disease. And I'm struggling with one patient right now, trying to figure out what the next step would be. But I'm using a regimen called RMBVP. So that has a high-dose methotrexate as well as etoposide and carmastine for systemic coverage. But I think the outcome for simultaneous relapse in the CNS and body is very, very challenging to treat. And outcome is poor generally.
Thank you. And another question I have on peripheral T-cell lymphoma. Which patients you will consolidate a case of PTCL with autologous stem cell transplant and which you will not consolidate with autologous stem cell transplant?
Yeah, I think the only ones I don't consolidate are ALK positive anaplastic large cell lymphoma. Otherwise, any other PTCL, irrespective of stage, I do discuss autologous stem cell transplant. Now, if you have a low IPI, limited stage disease, I mean, they could choose to not undergo the autologous stem cell transplant consolidation because the data for that is really based on, single arm phase 2 studies. There's not a randomized study of transplant versus no transplant that definitively says that transplant is the right answer. So If you have ALK-positive anaplastic large cell lymphoma, no auto transplant. If you have a low IPI PTCL who achieves a complete remission at the end of treatment, you can potentially forego an auto transplant. But for everybody else, I do recommend it if they're candidates.
My last question is, in case of PTCL, which other patients will benefit by adding etoposide, CHOIP regimen? So
Yeah. So to be honest, the algorithm for PTCL really depends on CD30 status. So if they're CD30 positive, my frontline choice is using BV-CHP as per the Echelon 2 data. For patients who are CD30 negative is when I'm thinking about etoposide. So patients who are younger than 60 years of age and typically with angioimmunoblastic T-cell lymphoma, I tend to include etoposide, or if the patient is presenting with HLH, irrespective of the histology, then there's benefit to adding etoposide. So those are maybe the three situations where I would consider etoposide: CD30 negative, young, healthy patient, AITL, or HLH in the background.
Thank you. Thanks a lot.
Priyanka, what is your approach for a very elderly, unfit angioimmunoblastic, say 85 plus?
Yeah, very, very challenging, right? Usually they're very debilitated from their disease as well. So again, if CD30 positive, even in AITL, you could use brentuximab vedotin. And maybe you want to use just single agent brentuximab vedotin since you probably don't want to add chemotherapy to this 85-year-old, or you could use brentuximab in combination with bendamustine in that situation if they have a high disease burden. If disease burden is not high, you could get by with just single agent BV. Or there is data to use agents like duvelisib, using azacitidine as an option, but we are talking palliative regimens, which we will just be controlling and maybe helping symptoms. Or many times these patients don't want treatment and you just use steroids for symptom control and let the disease take its course.
Azacitidine monotherapy has any role in palliative setting?
Yes, there is data to support azacitidine in PTCL.
Thanks. Before we go to Dr. Deepak, we'll take up one or two questions from the audience. Dr. Avinash Pofli has a 85-year-old male patient, no comorbidities, non-GCB, double expressor DLBCL. Performance status 1, stage 2, your regimen.
ABC type DLBCL, 85-year-old. I think I would use our mini CHOP in that setting.
Right. Dr. Aishwarya has 47-year-old male diagnosed as follicular lymphoma 7 years ago. Received Benda with Obino, 6 cycles. In the last follow-up, there is a relapsed follicular lymphoma. What is your approach and what's the role of R-CHOP now?
So if it is relapsed follicular lymphoma after Benda Obina, I didn't hear. So the remission was many years, or was it short?
Many years, 7 years.
Many years, 7 years. First question, is the patient symptomatic? If the patient is asymptomatic, this is low disease burden, you can continue observation without any treatment for right now. If the patient is symptomatic or the disease burden is high, meaning multiple areas of more than 3 centimeter lymph nodes or bone marrow involvement causing cytopenias, I mean, if they need treatment, you can use lenalidomide-based treatment would be my choice in the second-line setting. So R-square may be a consideration there.
Thank you. Dr. Thanda from Myanmar has a question about your experience regarding side effect profile of ibrutinib.
I'll talk about the most commonly used setting, which is CLL, right? So in CLL, ibrutinib, I think even though we talk about side effects, it is a well-tolerated drug, but the main things to watch for are atrial fibrillation and bleeding. So I've seen everything from like spontaneous subdural hematomas and atrial arrhythmias leading to death, to like having increased bleeding and bruising, headaches, hypertension, other things that can be more easily managed. I think the place to be very cautious is patients who already are on anticoagulation. Definitely don't want to give it in combination with warfarin, but the oral DOACs are okay in combination with ibrutinib, but you have to be very cautious about the bleeding risk. If they're undergoing any elective procedures, holding the medication is important. If they are, in an emergency situation, then transfusing platelets, even with a normal platelet count, to prevent the bleeding risk from the ibrutinib is important. So I do think it is, the problem is the risk of side effects remains for as long as the patient is on the medication. So even though they may tolerate it for the first 2 years, at year 5, they may end up with atrial fibrillation or a bleeding issue. And so it is that continuous monitoring of side effects, which is important with ibrutinib.
So Roshni has a question about relapsed refractory Hodgkin lymphoma, about low-dose nivolumab, 40 mg.
I don't know much about that.
European data saying it is equal. That's about all.
Okay, I don't know much about that. That is not the approval, and so we don't use it like that. So interesting.
Deepak, your question.
Thank you for that excellent discussions. I have 3 questions. So first 2 are related to transform lymphomas. So in the context of richer transformation, there is a role for an autologous transplant. I had a couple of patients, 30-year-old, who was marginal zone lymphoma, who has come with a large cell transformation upfront, the Chi of close to 70%. So post R-CHOP, is there a role for a conservative autologous transplant in this particular scenario?
Clarification that Richter's transformation is what we call CLL transformed to DLBCL. This is a marginal zone lymphoma transformed to DLBCLs. I wouldn't think of it as Richter's. I would call it a transformation from an indolent lymphoma. In this situation, I don't feel too strongly about an autologous stem cell transplant consolidation, and that's because the underlying lymphoma was untreated, and then there's again the data says that if you have an untreated underlying indolent lymphoma with a transformation, the outcomes of the DLBCL are similar to de novo DLBCL. So I wouldn't necessarily think about consolidation auto in CR1 in that situation. If the patient had received multiple treatments for marginal zone and then transformed, then maybe an auto is more appropriate.
In similar context, a patient with follicular lymphoma who is present upfront with the DLBCL component, is there a role for maintenance post R-CHOP?
Yeah, so that is one situation where I consider maintenance, and that's because you are trying to maintain the follicular component as well as maintain the remission that you achieve for the aggressive component. And so I have used maintenance post R-CHOP in these situations.
Third thing is regarding mantle cell lymphoma. So do you still see that role of transplant in P53 mutated mantle cell where you are using the newer regimens?
No, I think TP53 translates to poor chemosensitivity. And so sometimes when they present with disease burden, you have to start with a chemo regimen and they do have a response. But most of the time that response is transient and short-lived, so PFS less than a year. And so giving them autologous stem cell transplant generally does not add to their PFS, but definitely adds significantly to toxicity. So I do not give them autologous stem cell transplant. What I discuss with them is maintenance BTK inhibitor based on the triangle study that was presented now in 2 ASHs ago.
Thank you, Deepak. The question by Dr. Hita about your choice of treatment for lymphoblastic lymphoma. She hasn't specified anything further.
So lymphoblastic lymphoma, we tend to treat more as ALL. So we would use an ALL-based approach like hyper-CVAD in that situation.
That's the last question in the audience side. Any questions from the faculty here? If no, then thank you, Dr. Priyanka. Another episode, wonderful presentation of your lecture. The hard work done by you to put up the data from the ASH together, which is, and I must say that the second part of the title, relevant to India, you did full justice to that. Sometimes we have talks which do not make much sense to most of the people who are listening to you. But today you did a wonderful job from the angle that each and every advance that you covered was extremely relevant, available in some or the other way. So most of us can practice that. So that was great. And the question answer session was fantastic. I'm sure everybody joins me in thanking you for updating everybody on this part of the world. And it's not just India. A lot of people from the rest of the world have also heard you today. And I'm sure that whenever we approach you, you will oblige us by talking to us. Thank you.
It has been a pleasure. Thank you so much.
Bye-bye. Intas is there for the word of thanks. No, they're not there. Thank you so much. Bye-bye. End of the day.